This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. Lafredo. Dr. Sandra Rubio is an endocrinologist at KRMC. She's board certified by the American Board of Internal Medicine in internal medicine and endocrinology, diabetes, and metabolism. Dr. Rubio attended Ponce School of Medicine in Puerto Rico. She then completed an internship and residency in internal medicine at Cabrini Medical Center in New York City. To further develop her specialty, she completed a fellowship in endocrinology and metabolism at St. Vincent's Hospital and Medical Center in New York City. Dr. Rubio has been with KRMC since 2022, and as we'll hear in the following interview, for nearly 30 years she has been providing treatment and management for endocrine disorders. Today, we'll discuss some of those with a focus on diabetes. Dr. Rubio, welcome.
Hi.
A lot of your patients come in because they didn't plan necessarily on coming to endocrinology, right? That's probably a good place to start.
It is a specialty within internal medicine, and we get referrals from the general population, usually from their primary care physician. Our biggest group that we serve is people with diabetes, which, as you probably know by now, affects millions of people in the United States. And unfortunately, it's a terrible disease. It's a chronic disease that has many complications. So we do work with those patients with diabetes as well as other conditions, including thyroid, pituitary, adrenals, and others.
These are the organs of the endocrine system, correct?
That's right. Endocrinology has to do with glands that release hormones that affect, amongst other things, your metabolism, your blood pressure, your blood glucose, your fluid intake and output, and your electrolytes, as well as temperature, growth, reproduction, and sleep, amongst other things. So it's a wide array of effects in our bodies, and a lot of people don't realize how much these little glands can affect the rest of your body.
Diabetes in particular, I know there are, 3 or maybe 4. I've talked with a few different people over the years. So there's type 1 and type 2, and there's gestational diabetes. And somebody said something to me about type 1.5, or is it something like that?
Right. The common term for diabetes of type 1 and type 2 is very simplistic because type 1, most people are familiar that typically occurs in younger people that have had their pancreas affected where they cannot produce any insulin. And most people are familiar with type 2 diabetes where their pancreas still makes insulin, but not enough to control their glucose. But there's people that fall in between those two.
Oh, okay.
And that might be what you're referring to, type 1.5, where they either started as type 2 and now they don't produce enough insulin, so they behave more like a type 1, or there's other different reasons to have diabetes, including damage to their pancreas for different reasons, including pancreatitis or surgery.
So as a sort of working definition, can we say that diabetes is a chronic disease that develops when the pancreas either doesn't produce enough insulin or when the body is not processing that insulin sufficiently?
Right.
Well, Dr. Rubio, what are some of the signs and symptoms of diabetes?
So the typical signs and symptoms include excessive urination, excessive thirst, blurry vision. Some people actually lose significant amount of weight prior to being diagnosed with diabetes. So those are some of the typical symptoms that we see before a patient is diagnosed with diabetes.
Is type 1 diabetes always genetic in cause?
Again, depending on the cause, a lot of our patients with type 1 diabetes do have a genetic predisposition for autoimmune disorders, which will attack their pancreas at a certain age.
But diabetes also has environmental factors.
Absolutely. Obesity is a major factor that's environmental that can actually contribute to our patients developing type 2 diabetes, where their pancreas has to overexert in order to maintain their glucose. So then there has been a term called diabesity because there's such a intimate connection between type 2 diabetes and obesity. So definitely targeting weight has helped prevent patients from developing full-blown type 2 diabetes.
A diagnosis of diabetes can really change a patient's life. What goes into managing this disease?
Absolutely. It does affect the day-to-day function of our patients because they do have to monitor their glucose levels, so that involves pricking their finger to check their numbers. Now we have more modern ways to check your blood glucose, which includes a continuous glucose sensor that patients can wear. They also have to watch their diet, especially concentrated sweets, as well as carbohydrates, which will affect glucose levels. So all of this needs to be monitored and managed by patients, as well as their activity, whether they're sedentary versus more active. That can have a reaction in their glucose as well. So as you can imagine, it really affects their whole life, and it can be tiring at times for patients since it's a chronic disease.
And for a patient who's recently diagnosed, there's a whole lot of education. There's a lot to learn and a kind of a new lifestyle that has to begin, right?
Absolutely. We do encourage our patients to receive as much information and education as possible. We do have a program here at KRMC called the Diabetes Disease Management, and it's run by the doctors in pharmacy, or PharmDs. And has been terrific for our patients because they can actually learn so much about their disease and what their medications can do and help them through their process, since they actually have to live with this disease day to day. And unfortunately, I'm not there all the time with them. They have to learn to take control of their own diabetes.
In the case of a patient who's, perhaps you mentioned diabesity, right? Maybe a patient who's in poor health and now has this diagnosis and just has to start fresh. As a starting place, what is something you would want that patient to know?
So patients should understand that we do offer many options in terms of medications that can help them through their journey. So there's hope. I've had many patients that have been able to manage very well their diabetes, and some of them can even reverse it in certain occasions. So not all hope is lost. I think it is important for patients to realize that they can do something about it. They can improve their mood, their levels, and they can change.
Well, Dr. Rubio, in preparation for today's chat, I did a little bit of research. You can correct me if these numbers don't sound right, but what I learned was that in the year 2000, about 30% of the U.S. population was classified as obese. And today, according to the National Institutes of Health, that number is at 43%. So here's what I'm wondering. As Americans have grown heavier, how has your work changed?
Absolutely. Education, again, is the key for our patients to understand that they can make some changes in their lifestyle to prevent diabetes, and that there are many options to help them with their weight issues and hopefully reverse diabetes or decrease the complications from diabetes and obesity too.
In recent years, we've heard a lot in the news about the GLP-1 receptor, which is also known as
Incretin mimetics.
Thank you. Incretin mimetics. Ozempic is the one that we hear about most commonly, maybe.
A lot of people are familiar with Ozempic, absolutely.
Other brand names as well, and they're being used for weight loss. Is this a part of your practice, and what is your experience with it?
Yes, those medications have been tremendous help for our patients. Many of our patients that were never able to manage their diabetes or their weight have had success with both those conditions by taking these medications. So they have been tremendous help in our fields.
Who is a good candidate for those drugs?
It's usually for patients with type 2 diabetes, with obesity, but it can be used in patients with obesity without diabetes. So these medications have been approved for both diabetes and obesity individually or separately.
Mm-hmm. Are there some characteristics or I guess what I want to ask is, are there patients who are not good candidates for these drugs?
So some of the contraindications to these medications include a history of pancreatitis because they have been rarely associated with pancreatitis. And the way these medications work, they do have some effects in the gastrointestinal system. So there are some people that are more sensitive to these medications, so they're not able to tolerate them. But other than that, like I said, many of our patients have benefited from the results of these medications.
If you're just joining us, this is Focus on Your Health. I'm TG Lafredo, and this week on the program, my guest is Dr. Sandra Rubio. She is an endocrinologist at KRMC Endocrinology. Dr. Rubio, as you know, Kingman and Mojave County are what are known as medically underserved areas. Do you face any particular challenges in your medical practice working in this context?
Actually, that's what attracted me to come to here, because I knew there was such a need for my services. So I feel really strongly that we're offering services to those underserved. So that attracted me a lot. I know there's limitations in our time available from me, since I'm the only of my specialty in the whole county. And we do get a lot of patients from even beyond the county, including Laughlin and Needles, Seligman, etc. Some places I don't even know.
You're busy.
We are busy, so there's definitely job security here. But it does give me tremendous satisfaction to be able to help these patients that otherwise wouldn't have been able to see specialists, or would have to travel quite a ways away or to a larger city. What I find is that a lot of our patients that live with what I consider a rural community like ours, they prefer to stay within our region versus traveling to Vegas or to Phoenix areas. So we offer that to them. We also can be a bridge, because some of our patients need more specialized person that can manage them for a short period of time, and then we can offer services in between those visits.
Yeah. Well, you talked about the need for endocrinology here. Do you sometimes see patients who have gone untreated for way, way too long?
Absolutely. Unfortunately, yes. For many years, some of our patients haven't seen an endocrinologist, if any. Yeah. Some of our patients that have had very serious endocrine conditions have never been seen by an endocrinologist before. I've seen some of our patients, so I am glad to have seen them.
Where does that office visit begin? What do you do when there's such a profound need? What's the first step for you?
Well, I do follow, for lack of a better word, a script. I like to ask my patients certain questions pertaining to their condition, so that way I will have a better background of where they are and where they have been. As you know, some people are a little bit more open about that information. Other people are more reserved. So I try to make that connection with my patients to try and assess their needs. So that's part of the art of medicine,
Yeah,
of
for sure.
how to communicate with your patients and let them share that very personal space.
You could have all the medical knowledge in the world, but if you couldn't express that, you would be of minimal help to your patients.
Absolutely. It is important to make a connection.
We know that you're busy. How do patients come to you? Is it only by referral?
Yes, we do ask for referrals. And I know some of our patients are a little put off by that because their insurance doesn't necessarily require a referral. But in our situation, we do ask for a referral only because the limit that I have in terms of time or that we have to offer. So in general, our department does ask for a referral just to help us accommodate them.
Mm-hmm. I have a question for you, a little bit of retrospective. I have a bio on you, and it says that you've been practicing endocrinology for over 25 years. In that time, we said that there have been certain social changes, such as, weight gain and some of these new drugs that maybe changed the game a bit for them. But when you look back on those 25 plus years, has endocrinology, is it largely the same, or has your field changed significantly?
It has changed tremendously. We are able to offer so much technology to our patients, especially in the field of diabetes, but even in other areas, we are seeing a lot of changes and we can offer a lot to our patients. So it has been tremendous and very exciting. It has kept us, even though I'm almost 30 years in, has kept me excited and looking forward to the new innovations that we can offer our patients.
Those 30 years or 30-ish, I guess I have an old bio for you, but
95 is when I graduated, but it's still not, because I graduated in May 95.
Yeah.
So this year will be 30.
That's fantastic. This is like your anniversary program.
Right.
Those changes and those evolutions in endocrinology should equate with better outcomes for patients. But as we said, we're seeing more difficult cases in terms of diabetes and, people maybe not taking care of themselves well enough. So they need to do their part of it too, right?
Right. And again, I think education is the key. And we try to educate at the more general medicine level because a lot of our patients, that's their first visit to medical care would be through primary care physicians. So we do want to educate the general practitioners and those that offer primary care services so that they can initiate the treatment and refer to us when it's adequate or appropriate.
We talked about some of the changes and the changes in technology. What is ahead for KRMC endocrinology?
Right. So we are offering insulin pump clinic at our office. And we do offer the upload and management of continuous glucose sensors to our patients as a standard of care. In the future, what I see, if possible, if we can join more providers in this practice, that could grow our practice and being able to see more patients that need this service and continue to work in conjunction with the diabetes disease management and maybe expand that program, that would be helpful to our area of need.
Oh, ay Dios. Y ahora, doctora.
Oh, sí.
Finalmente, tengo que decir que he estudiado español por varios años Y le dije a mi maestra que tengo esa entrevista con usted, una doctora originalmente de Puerto Rico, y mi maestra, que está en Quito, Ecuador, me dijo, tengo que hacerle unas preguntas en español. No estoy seguro si lo puedo hacer, pero si me permite, ¿está bien?
Gracias. Sí, seguro. Estoy muy encantada.
Sí.
Ahora mi acento ha cambiado mucho y mis amistades de Puerto Rico me dicen, bueno, ya no suenas puertorriqueña, pero así vamos.
Yo tampoco. Sé que tenemos una población hispana aquí en Kingman y hay pocos doctores que hablan español. ¿Alguna vez ha tenido la oportunidad aquí en KRMC de atender pacientes en su idioma natal?
Gracias a Dios, sí, muchas veces. Tengo muchos pacientes que son de ascendencia hispana y que hablamos estrictamente español.
Ajá.
Así que cuando viene algún paciente que necesita ese idioma, yo le puedo ofrecer. Y no creo que usted ha investigado que también hablo por señas.
No.
Sí. Así que esa es otra entrevista. Mi padre,
Sí.
él era sordomudo de nacimiento. Así que también tengo esa facilidad de hablar por señas.
Entonces,
Pero,
¿todavía lo puede hacer?
Sí, como cualquier idioma. O sea, la práctica es lo más importante.
Sí.
Y eso es lo que pasa con el español. Yo hablo un poco italiano, un poco francés y así. O sea, que cada idioma, pues, hay que practicarlo. Y bueno, si uno visita esos países o si tienes la oportunidad de practicar el idioma,
Sí.
pues eso le viene a uno más fácil.
Tiene razón. Y la otra cosa es que el lenguaje es un acuerdo entre dos o más, ¿no? Lo pienso frecuentemente porque mi esposa es de las Filipinas. Nunca estudió español, pero ahora tiene a muchos pacientes hispanos.
Sí.
Y puede hacer lo que tiene que hacer. Pero la otra cosa es que son o forman un equipo, ¿no?
Sí.
Es que con el español que ella sabe, más el inglés que ellos saben, juntos pueden hacer lo que tienen que hacer.
Eso es así.
¿Sí?
Sí.
Otra cosa, última pregunta, si me permite. En el campo de endocrinología, no es fácil para mí decir eso, ¿qué recomendaciones podría darles a las personas de bajos recursos para mejorar su nutrición?
Sí, nosotros sí discutimos qué comen los pacientes. En esta área, la tortilla
Sí.
es muy común. Le decimos a nuestros pacientes que limiten la cantidad de carbohidratos. Eso incluye las tortillas, eso incluye el arroz,
Por supuesto.
eso incluye las papas. Y bueno, le pedimos a los pacientes de que limiten la cantidad, que sí pueden comer algo, pero no demasiado. Y eso les ayuda a ellos a entender de que esos alimentos le pueden causar problema del azúcar.
Hay que encontrar otro camino, ¿no? Porque son las comidas más ricas, es como lo que se come durante una fiesta. Es difícil hacer este cambio,
Cierto,
¿no?
y especialmente la cerveza.
Sí, por supuesto.
La cerveza yo le digo que es pan líquido.
Ajá. Sí.
Sí,
Tiene razón.
así que todo eso tienen que saberlo. Algunos pacientes que se sorprenden, o sea, que no sabían hasta ese momento que eso le puede afectar. Así que entonces le decimos a ellos, sí, por favor, limite la cantidad, no que lo elimine completamente, sino que coma menos o tome menos.
That is Dr. Sandra Rubio. She is an endocrinologist at KRMC Endocrinology, and she's super fun to talk with. Dr. Rubio, thank you so much for your time today.
Thank you. My pleasure.
And that is the program. That's Focus on Your Health. I'm TG Lafredo. Thank you for listening. Stay healthy, and we'll catch you next time.